Greetings everyone, and welcome to my presentation on lichen sclerosus. Alright, for a bit of overview information, lichen sclerosus is a chronic inflammatory skin disease that typically affects the genital areas, but it can also occur in extragenital regions, including the neck, chest, torso, upper back, wrists, and mouth, among other areas. This typically manifests as itchy and painful patches of thin, white, wrinkled-looking skin, and typically progresses to scarring or skin tightening, and it can also increase your risk of developing squamous cell carcinoma. This disease appears to be rare, affecting roughly 200,000 people in the United States. But it's also been suggested that this disease is severely underreported due to provider lack of familiarity, asymptomatic presentations, and discomfiture or shame. There's a higher prevalence in women, peaking in prepubertal and postmenopausal ages. The prevalence among women is roughly 1.7%, while among men it's 0.03%. The etiology of lichen sclerosus is currently unknown, but it's been proposed as a multifactorial disease involving genetic, autoimmune, hormonal, and local influences, among others. We will focus in later on a few key factors involved in disease development. I've highlighted them here. Up at the top, we are mainly looking at HLA serotypes under the genetic predisposition category. HLA is human leukocyte antigen, but we will get into that more later. Moving down to immune dysregulation includes the dominant Th1 response and hypersecretion of pro-inflammatory cytokines. Immune dysregulation leads to upregulation of microRNA 155 and enhanced fibroblast activity under the abnormal collagen metabolism category, and development of ECM1 autoantibodies under the chronic tissue damage section. These factors ultimately contribute to changes to the skin, including thickening, hardening, and atrophy. There are currently three competing theories for the primary cause of development. First, infections may trigger and sustain an immune response. Next, autoimmune. This theory suggests that chronic immune dysregulation, or autoimmunity, allow or assist in the development of LS, and chronic irritation, suggesting that exposure to liquid irritants, urine for example, causes trauma to the skin and triggers the disease. Looking into the infectious theory, researchers have investigated B. burgdorferi, Epstein-Barr virus, hepatitis C, and human papillomavirus to assess correlation with LS development. They found that each pathogen was associated with LS in a range from 0 to 75% of cases. It appears at present there is insufficient evidence to suggest LS develops from the presence of infections alone. Moving to the autoimmune development theory, the HLA-DQ7 serotype. Now, we could make a whole separate presentation on this alone, as it's very complex, but I will stick to the basics here. HLA-DQ is a receptor for both foreign and self-antigens on the surface of antigen-presenting cells, including macrophages, dendritic cells, and B cells. The genes for HLA-DQ are inherited. Now, a distinct variation of HLA-DQ, the HLA-DQ7 serotype, presents self-antigens to T cells and stimulates antibody production. This serotype is associated with several autoimmune diseases, including celiac disease, hepatitis, and rheumatoid arthritis. The serotype has also been associated with development of lichen sclerosus, as it is more common in individuals with the disease. This serotype confers genetic predisposition to the development of autoimmune conditions, since the body makes antibodies against self-antigens. We also detect an upregulation of microRNA 155 in LS patients. This reduces the suppression of T helper cells, which are involved in coordinating the immune response. This amplifies the immune response and promotes proliferation of fibroblasts, leading to the skin thickening and scarring that is observed in patients with LS. A Th1 dominant inflammatory profile is also associated with LS. The Th1 response is directed against intracellular pathogens and is pro-inflammatory as a result of cytokine release. ECM1 autoantibodies are also detected in LS patients. The ECM1 antigen is involved in cellular growth and differentiation, angiogenesis, skin integrity mainly, and adhesion and signaling. Pathogenic loss-of-function mutations in the ECM1 gene have been associated with the development of LS. It has been proposed that circulating autoantibodies disrupt the function of ECM1 and contribute to the diseased state of tissues in lichen sclerosus. T-cell clones are also overabundant in LS patients. These clones are a population of identical T cells that share the same unique antigen-recognizing receptor. Put simply, all T-cell clones are capable of fighting against the same pathogen. The last theory for the development of LS is chronic irritation. Here, LS develops as a result of trauma to the skin. This is called an isotopic response, or the onset of a new skin disorder at the locus of skin trauma. This theory is not favored due to the rarity of LS in circumcised males, the absence of perianal disease in men, the prevalence of perianal disease in women, and localization to the occluded epithelium. So let's talk about some risk factors. I mentioned previously prepubertal or postmenopausal age in women is a significant risk factor, as well as genetic predisposition through the HLA-DQ7 serotype. The absence of circumcision in males, presence of autoimmune disease, diabetes, obesity, and genital skin injury, friction, piercings, or surgery can also increase your risk for developing LS. Diagnosis typically involves presentation of signs and symptoms associated with lichen sclerosus. However, differential diagnosis is important since many other conditions can present with similar symptoms. A confirmatory biopsy is often taken for histological inspection. LS histology reveals fibrosis of the superficial dermis. This is a result of increased proliferation of fibroblasts and accumulation of collagen, which leads to a thickened connective tissue layer. Depending on the stage of fibrosis, this layer may also be infiltrated by lymphocytes. In the image here, these cells are present and appear small with dark nuclei and minimal cytoplasm. LS patients are often prescribed topical corticosteroids like clobetasol. Clobetasol is a glucocorticoid receptor agonist, increasing the production of anti-inflammatory proteins like lipocortin-1 and decreasing the production of pro-inflammatory cytokines by inhibiting prostaglandins and leukotrienes. There are risks associated with prolonged use of topical corticosteroids, like skin thinning and systemic absorption, so there are other management strategies available. Now, we don't fully understand the exact mechanism or cause of lichen sclerosus development, and it is a multifactorial disease that involves interactions between various biological pathways. For this reason, there is no cure. LS treatment instead focuses on managing the patient's symptoms and preventing the disease from getting worse. I'd also like to mention that while there is a risk of skin thinning associated with topical steroids, some patients may be unresponsive to topical steroid treatment because there is extensive skin thickening that prevents dermal absorption. For these patients, steroid injections may be recommended. In this case, triamcinolone is injected directly into the lesion, and the dose is dependent on the extent of thickening and location on the body. Another class of drugs used to treat LS is immunosuppressants, including tacrolimus and pimecrolimus. There is no risk of skin thinning with these topicals. They act as calcineurin inhibitors by binding FKBP12, preventing the progression of signal transduction. This prevents activation of calcineurin phosphatase and subsequent dephosphorylation of NFAT. Ultimately, these drugs suppress or fully inhibit the production of several cytokines. Specifically, interleukin-2 production is suppressed, while interleukins 3, 4, and 8 are inhibited, as well as GM-CSF, which is granulocyte macrophage colony stimulating factor, and TNF-alpha, or tumor necrosis factor. Both cytokines, GM-CSF and TNF-alpha, are key mediators of inflammation and the autoimmune response. Other treatments include phototherapy, cryotherapy, and surgery. Phototherapy and cryotherapy are commonly used to treat extragenital LS. Phototherapy acts on T cells by inhibiting their activity and inducing apoptosis. It also promotes the shift to production of anti-inflammatory cytokines, reducing the cytokines involved in skin thickening and fibrosis. This process effectively limits scarring, and it decreases fibroblast activity that is responsible for the hardening of skin tissue. Cryotherapy is used to relieve itching symptoms by temporarily desensitizing nerve endings in the skin. It also kills cells in the targeted skin layers and destroys abnormal or excessively thickened tissue, and it decreases fibroblast activity as well. Surgery is recommended for patients with altered structural anatomy due to scarring or stricture and is used to restore or maintain proper function. Local estrogen treatment using estradiol or estriol is an adjunct therapy for female LS patients of postmenopausal age with atrophy present. This treatment is used to improve tissue health and integrity. Now looking at some new treatments for LS, PRP injections, or platelet-rich plasma injections, are used to stimulate tissue repair, assist in collagen remodeling, and increase skin elasticity. PRP injections are not a new treatment. They have been used to treat many other diseases, but they are a newer treatment for LS specifically. PRP is generated by drawing the patient's blood and spinning it down, and it amplifies the growth factors in platelets. Upon re-injection, the platelets degranulate, releasing growth factors that aid in tissue repair. Another treatment, the tulip treatment, combines phototherapy and PRP injections. This was created by an LS specialist at the Coyle Institute and uses a profractional laser to remove damaged tissue and PRP injections to stimulate tissue repair. Lifestyle modifications for LS patients includes establishing a proper skincare routine, wearing loose-fitting underwear and clothing, avoiding wool, silk, or otherwise irritating fabrics, taking lukewarm showers, using unscented laundry detergent, and avoiding long bike rides, motorcycle rides, and horseback riding. I used an AI program called Elicit to assist throughout the project. This is basically Google, but for research papers, and I used this as a search engine to find research papers that were relevant to topics within the presentation. And here are my references. I hope you enjoyed my presentation on lichen sclerosus. Thank you and have a great day.